I'm Dr. Steve Thung. I'm a maternal fetal medicine specialist. I happen to be the new chair of the Obstetrics and Gynecology department. And I would say that we're going to talk about so many touching, challenging topics that are very sensitive and very difficult for our patients as well as the providers. Especially as an obstetrician, we're so used to happy outcomes. People always ask me, Steve, why did you go into obstetrics? And I said, because it's a really happy field. For the most part, we can take care of events where people are growing their families and growing the roster of their family. But we also know as physicians that is not always the case, right? That there are cases, there are patients and families, right, that don't have the outcomes that they were hoping for.
The grief that results from perinatal loss is complex and unique. It involves a sense of biological failure, loss of self, lack of memories surrounding the baby to use in the mourning process, loss of parental future hopes, and minimization by others.
And she's questioning everything, right? Between sobs, she's saying to me, in her words, I'm so sorry. Is this my fault? What should I have done differently? What's this going to do to me? What's this going to do to our marriage? Each of these questions are really heavy, and she's asking me all of them at once.
Within minutes, I was induced to deliver, and once again, I felt totally unprepared, overwhelmed, and petrified to go through something I really didn't believe I could handle. Clinically, I was told there was nothing I could do to prevent my milk from coming in, and the experience of having milk yet no baby was brutal. Joseph was due on St. Patrick's Day, so our lactation specialist advised me to wrap my breasts in cabbage leaves to ease the pain. To this day, my daughter still associates cabbage with that experience. It took a long 6 weeks to get the autopsy results, and during that time, I repeatedly played back the events surrounding labor and delivery and wondered why it all happened. I would also open Joseph's memory box and look at his pictures when I questioned if it really had happened. When you don't bring the baby home, there's no evidence that it was real. I now know that was a symptom of my grief and anxiety, but I didn't connect the dots at the time. I was warned I may not get an answer, but I prayed for some closure. And during that time, this picture, my brother-in-law sent this picture to me that he took, and it gave me hope the day I went back for the autopsy. The doctors confirmed that Joseph did have Down syndrome and duodenal atresia and died in utero due to complications. It was a relief to get some answers, but the grief remained. I went for a physical, convinced that the doctor would figure out that something was wrong with me, and that's why it all happened. He told me that although I was healthy, my body recognized that something was wrong with the baby and rejected it. So think about how his choice of words may have impacted me. He said that my body rejected the baby. And although I knew what he meant clinically, his words reinforced what I already felt, that I was to blame. My underlying fear was that I would never recover from this, but I was committed to healing in a healthy way.
So I like to use this picture when I talk to residents and medical students as an expression of hope. I consider this all a time for searching and a yearning for these very painful emotions that we all go through. That when outcomes of our patients' pregnancies end in miscarriage, stillbirth, and infant death, we struggle to find the right approach to break the news to them, to treat them medically or surgically, to help them recover physically and emotionally, and console them in their grief. Most of us, as Dr. Thung mentioned, have not been taught to provide this bereavement care, including myself. It's all, for me, it's been a self-taught process. We can do the D&C, we can attend and assist in the birth of the baby who has experienced the intrauterine death, but we learn fast that there are hospital nurses and social workers, bereavement counselors and therapists, support groups, and religious ministries to whom we can refer our patients for immediate bereavement care. Fortunately, we're able to do that and subsequent follow-up. But when we hold in the palm of our hands an 18-week fetus immediately after our patient miscarried or attend the stillbirth of a term pregnancy, our intellectual knowledge and rational thought fades as we struggle to find the right words to say. Unlike the repetition of performing a surgical procedure, no matter how many times we've experienced the loss with our patients, it does not become easier. I was at one conference and someone said, "It's so nice to meet you. You're an expert in this." And I said, "I'm not an expert. I don't think anyone can be an expert in this. It's something that we develop a way of talking with our patients, but to be an expert is a different vernacular." Sorry, that's flashed up there. A stillborn baby or a baby who has died as a newborn represents the greatest of emotional and management challenges, and the grief that our patients feel is enduring and can be lifelong. And I just want to take a moment to show you this picture. This is a picture from a gravestone that is in the St. Bernard Cemetery in New Haven. And I was part of a service where this gravestone was laid, and it was laid and a memorial service was carried out for babies that were born still and placed in mass graves at St. Bernard Cemetery. And the families did not know where their children were buried. They were not able to go there to pray or to just be with them. There was no marker. And a group of families in New Haven got together and they found, we were able to work with them, and they found where their babies were. They exhumed all the remains and put them under this marker. But what's even more important is that this was written up in the New Haven Register, and someone read this article, and this person that read this article was over 60 years old. And she called me and she said, "Dr. Berman, I saw this article about babies that were buried. I don't know where my son is 40 years later." 40 years she was thinking about where her son was buried, and we were able to help her with that. And I only bring that up for you to understand that this is a lifelong, enduring process that no one will forget. We must recognize that these losses as a life-altering event for our patients in care. When we care for our patients that have had fetal deaths, intrauterine deaths, stillbirths, I believe it can be a paradigm. As I talk to medical students, as I talk to young residents, a paradigm for what we do as physicians, because it tests not only our clinical skills and our judgments, but it stretches the fiber of the human aspect of caring. And that's what we really have to emphasize, particularly in the modern era of so much technology. We never can forget the human aspect of caring. And we might ask, how can we heal when our patients or our children are incurable or are dying? How can we do this healing that we are committed to? And we have to understand that we can heal by our presence. We can heal by giving comfort, and we can heal by empathy and hope.
When you are reading about stillbirth and thinking about it, think about the definition. Depending on the publication you're reading or the circle you might be in, the definition varies. But for today, what we're talking about is an intrauterine death at or beyond above 20 weeks of gestation. And there's a large burden worldwide of stillbirth, more than 3.2 million stillbirths annually. The vast majority of these come from low and middle income countries. You can see here in this figure that they're mixed between early fetal loss, defined as less than 28 weeks, and late fetal loss, so 28 weeks and beyond. And you can see the rate in your x-axis. In the US, there are approximately 24,000 stillbirths annually, and this breaks down to about one stillbirth for every 160 live births. There is a lot of variation in stillbirth rates across our own country. And when we think about variation, we can see opportunity to ensure that we continue to lower stillbirth rates across our patient populations. And when you look at some of the patient demographics, you can see that our non-Hispanic Black patients shoulder a disproportionate burden of stillbirths. And so there is a significant health inequity on all levels of maternal and perinatal care when we look at race and ethnicity. And it's particularly apparent here in this graph, looking at the rates of stillbirth across race and ethnicity. And when we think about etiology, there are myriad factors that can cause stillbirth. And we know that the understanding the etiology is limited by an incomplete evaluation of the stillbirth presentation. But stillbirth can be secondary to congenital disorders, birth defects, and genetic abnormalities, for example, infarcts and thrombi of the placenta and umbilical cord. There can be fetal maternal hemorrhage, growth restriction, infections, various congenital infections and maternal infections, maternal medical conditions, and we think about things like pregestational diabetes, cardiovascular disease, lupus, and then pregnancy disorders. The one that probably comes to most people's mind is preeclampsia. This is a large driver worldwide of stillbirth and the associated abruption that can happen in the setting of hypertension. Intrapartum stillbirths, and that leaves us about 30% of stillbirths that are unexplained. And then we can think about risk factors. So there can be the cause, but then there can also be mitigating factors that may maybe increase or decrease a patient's risk for having stillbirth. And this is a really nice way to break it down when you're talking to your patients, when you're talking to your colleagues, trainees, and thinking about the different categories. So it can be at the fetal level, the obstetrical level, the maternal level, and the environmental level, or the socio-demographic level. And this is where our social determinants of health also have play a role. And you can see too how all of these various risk factors can overlap in ways that are going to be unique for your patient, and they can also be they can interact with each other, and they could potentially exacerbate risk. So someone's risk of stillbirth and setting of diabetes from one person to the next might be different depending on their socio-demographic factors, for example. And so in thinking about this background, we sought to evaluate our stillbirth experience here at Yale New Haven Hospital, and we looked at stillbirths from 2013 to 2019. We identified 184 cases, and this included cases of stillbirth that were managed by cesarean delivery, vaginal delivery, as well as dilation and evacuation. We use the definition of 20 weeks and beyond. During this time frame, there were over 35,000 deliveries for a stillbirth rate of 1 in 190 live births. We identify the cause of stillbirth in approximately 76% of the cases. And in using a consensus review, as well as a detailed assessment evaluation, we concluded that over 27% of the stillbirths were possibly preventable. And you can see one of the tables from the work that we did, and two of the the strongest factor associated with stillbirth was substance use in pregnancy for being in determining preventability. So a lot of opportunity around substance use disorder in pregnancy for reducing preventable stillbirth. And so in summary to this project that I really gave you a high level view of, we felt that more than a quarter of stillbirths are potentially preventable.
You're like, well, then if that's the case, that must be me. and help them understand, I recognize you're trying to make sense of this and it doesn't make sense to you. That does not mean that you are to blame. That does not mean that your guilt is well placed. So you can have the thought, but don't make it fact. Help separate it out a little bit. And also I tell them, you're going to jump around, maybe moment to moment, maybe hour to hour, maybe day to day, but you're going to jump around and have a lot of different feelings, and that's okay. And we have space here for all of those feelings. We can handle your anger, we can handle your fear, we can handle your shock, whatever it is that you're experiencing. We want to make sure to help them make memories. Everyone actually referenced this already. One of our families, before we started this program at a hospital, said that she lost her daughter and she felt like she lost the ability to make memories with her because no one told her what the options were. So, and actually I'm going to jump down to the bottom where it says time. We can pair those two. If we give people time to ask questions, to process what they're going through, we also give them the opportunity to make memories and to also change the decisions that they make. I said that I did not want to see my child after my child was born. I didn't say it because I didn't want to see her. I said it because I had no idea what I was going to experience, and I was terrified. And when someone came to me and said, hey, let me sit down and tell you, like, your daughter is going to be maybe a little discolored, but I'm going to take her into the other room. We're going to wash her. We'll bathe her. We'll clothe her. We'll bring her to you. And she is beautiful. That gave me then permission to feel like, oh, this is okay. I can do this. And giving people permission is really important. Dr. Berman referenced this also about the words mattering. So did Dr. Campbell. Every word matters. More importantly, the words that we shouldn't say. So if you say something and you know that came out wrong, apologize right away. That's okay. Sometimes I say things with patients and I'm like, you know what? That really wasn't what I meant to say. Let me reword that. And they forget it. But if we don't say that, if we don't correct it, they remember it, and they remember it for a really long time. All our words matter. Also, please keep in mind, if the patient's in another room, if you think the patient is sedated, your words still matter. They hear much more than you think they hear. So everything we should do should be encompassing this patient and their child as though the child were living. And if we show that kind of respect, they're really going to feel it. Oops, I'm jumping way forward. Some things you can say. I love to say to families, you may not know what you need right now, because guess what? Most of them don't. Most of them haven't been here before. Leslie Shanahan's going to talk to us later about our resources. That is a really great way for us to say, would you like us to talk about what other families have found helpful? Some people want to see their baby, others don't. That's okay. But if you want to hear what other people have found helpful, we can share it. I often say this is overwhelming, I know, and it may feel hazy. You may have questions that you want to ask again and again and again. You may go home and say, wait, I know that we talked about that, but I don't remember what we said. That's okay. You don't have to remember it. You don't have to write it down. You can come back to me. I'm here for the long run. For you physicians that are here, studies show that families who are mothers who are made to wait more than 24 hours after they learn of a demise in order to start the process of delivery have a 5-fold increased risk of long-term anxiety. Think about it. If you go home and you have to engage with your other children or work or go to the grocery store or walk to the mailbox and you see people who are congratulating you about your pregnancy and your baby has died, it's horrible. The faster we can help these families make a decision about what they need and what they can do and then implement it, the better off it is for them. Please review the physical impact of the loss on the mom's body, lactation, bleeding, recovery. Also, maybe not at this, immediate stage where they're going through the loss, but soon thereafter, talk about future intimacy with the partner. They are going to have trouble asking about this because for a lot of families, it feels like if I ask, somehow it's going to seem like I'm not grieving, that I'm thinking about having another pregnancy or being intimate with my partner. But it is a part of their life and it is something that they need to understand. And also, it may not be the same. For most of our families, it's really hard to have intimacy after a loss because it comes with so much emotion. And if they know from you that that's normal and that that's okay, and that if they have questions, they can ask it, that can be really helpful. And if they have questions that you're not comfortable answering because they're more about emotions, then refer them out. Call and check on them. We talked about that. Oh, make sure future OB appointments are canceled. To get a MyChart reminder for an ultrasound is so painful to have to go on and cancel all those appointments. And also, if you're doing a follow-up with them, have the follow-up be first thing in the morning before any other patients are there. For them to sit in a waiting room with a bunch of other pregnant people is really, really hard. And if you have someone in your office that they can directly call when they have questions, so they don't have to filter through the main number and explain to every single person why they're calling, that's really helpful. Couple of, am I running late? Am I okay on time? Considerations for mental health complications. So if you have a multiples pregnancy and you lost one of your multiples, but carried the other or others to term, guess what? Most of the world is going to completely ignore the fact that you had a loss. And they're going to assume that you're just so happy that you have one living child instead of that you're grieving the child that you lost. We would never do this to a parent who lost a child and then had another child, right? But for whatever reason, we do this with multiples. Let us be a place where they can speak to both their children. They can talk about the child that's lost. They can talk about the child that's living.
They take it further to say that perinatal palliative care is really dual focused on ameliorating the suffering and honoring patient family and values, and can be provided concurrently with life-prolonging treatment, which I think that I want us to really focus on that today. We often think about palliative care as comfort care only, and really it should be along in all of those scenarios, whether families are choosing termination, comfort care, or medical interventions. And so who provides this care? It can be provided by a whole team of providers across various disciplines. And so oftentimes it includes obstetric providers, maternal fetal medicine providers, neonatologists, other medical subspecialists like geneticists, cardiologists, surgeons, any, depending on what the anomalies are. Nursing colleagues often get involved with these families prenatally, as well as a whole host of psychosocial disciplines, including social work, chaplain, and even child life. With perinatal palliative care, there's a distinct focus on emotional, social, and functional support of the pregnant woman and their families. And the goals are really to understand the value system that parents place in that parental decision-making, building a longitudinal care relationship from the time of diagnosis all the way through the time of delivery and beyond, and guiding goals of care discussions. And the end goal is hopefully a creation of a comprehensive palliative care plan that encompasses the remainder of that prenatal care, the perinatal care, including delivery preferences for that family, and postnatal and neonatal care. And so why should patients receive perinatal care? And I think it's really important to look at the numbers. And so we know that over 1 million fetal deaths occur in this country every year, and an additional 15,000 fetal deaths occur, and an additional 15,000 neonatal deaths occur each year. And an estimated 3% of all pregnancies are actually complicated by some of these life-limiting fetal diagnoses. With expanded genetic screening and advances in imaging technology, we're diagnosing these fetal life-limiting conditions much earlier. Therefore, increased numbers of U.S. families are seeking support in this decision-making process. And that leads to increased opportunities for these interdisciplinary evaluations and increased access to perinatal palliative care. An estimated 20 to 40% of families with life-limiting fetal diagnoses actually do choose to continue their pregnancies, and we find that that number is increasing as families become more aware of perinatal palliative practices. And about 60 to 82% of those pregnancies result in a live birth. And so the numbers are there. These families need our support, and we need to build these programs to support them. Additionally, we know that the importance of quality and collaborative perinatal palliative care is really well recognized. When families face the diagnosis of a life-limiting fetal condition, they often experience a loss of identity and isolation. I'm sure you face that a lot with our families, Elisabeth and others. They then seek opportunities to regain a sense of control in a time period when they feel like they have none. And so that decision-making piece, even when they're deciding for how they want to deliver, what they want that care to look like afterwards, that allows them to gain back a little bit of that sense of control. Perinatal palliative care provides an opportunity for those parents to actively parent. So they've sort of lost that idea that they're going to have a normal experience as a parent. And some of these perinatal palliative practices can give them that experience of being a parent back, leading to better empowerment and enhanced bonding with their infant even before delivery. Parents are often seeking respect and acknowledgement for their child's life, and perinatal palliative care practices can really support that. And so who should receive perinatal palliative care? Again, it's typically reserved for families choosing to continue a pregnancy. But if you think about perinatal palliative care as a true philosophy, it really can be applied to all families who are facing this life-limiting fetal diagnosis, even if they're choosing a termination. And so it really should guide care from the time of diagnosis to support these families through all phases of uncertainty and decision-making. And I'll include here another definition. So what are we talking about when we talk about life-limiting conditions? And so the definition I'll share with you today, and I'm sorry that the slide got a little mixed up when we transitioned it over to your format. Sorry about that, Elisabeth. And so when we talk about life-limiting conditions, we're talking about one that has a low likelihood of long-term survival without severe morbidity that could impact quality of life. And so the titles that were here are, this would include lots of different genetic and metabolic conditions, cardiac conditions, conditions that would lead to severe pulmonary hypoplasia, central nervous system conditions, as well as a whole host of others. And more recently, people are also including periviable infants, infants delivered at 22 and 23 weeks as infants and families who could really benefit from perinatal palliative care practices. And so what can palliative care look like in actual practice? And so there are different levels, and I'll share a slide on the next screen that goes through those, whatever value system the family uses to make their decisions. So inquire about spirituality and religion. I think sometimes we're uncomfortable doing that because we don't know how to respond to it in the end, but asking about it can really help you better understand where they're making their decisions from, and assist with putting those values in the context of their infant's care. Align with values and hopes. Once you've gone through these other three, summarize what they've told you, repeat it back to them, seek verification. It sounds like your religion is really important to you. Do I have that right? Voice things back to them. And then propose a plan. And I think sometimes we're a little, I don't know if scared or worried about proposing a plan. I think sometimes as providers, instead, we often give a laundry list or a menu of the different options. And so I'm going to push you instead to think about making a recommendation, but you can only do that once you have a good understanding of what that family's goals are. And so suggesting how identified goals may be achievable. It sounds like time with your infant and your infant's comfort are most important to you. Given that, I recommend that we create a plan that focuses on these as priorities. So what is, in the end, what is the birth plan hoping to accomplish? So it really does function as a communication tool between family and providers and among care team providers. It can be viewed as an advanced care directive, and so it really should exist in mom's chart so that everybody can access it. So no matter where she and the family enter the system, that information is there. Care plans should be structured, but they should be unique to each family and their experience. And they should reflect discussions with both the medical care teams and then created along with the support of the perinatal palliative care providers. So when I talk about the evolution and the creation of this birth plan, it is often not one person sitting down with a family. It is actually conversations that happen over time with multiple different providers that hopefully then come together in this birth plan for this family.